My second talk is atrial fibrillation, rate or rhythm control. The agenda for this talk, we'll start with describing the twin epidemic of cardiovascular disease, the ugly sister, heart failure and atrial fibrillation. We'll stress on the stroke prevention in patients with heart failure and atrial fibrillation. We'll discuss rate or rhythm control in patients with heart failure, and we'll briefly describe the role of AFib ablation versus antiarrhythmic therapy in patients with atrial fibrillation. And finally, we'll talk about issues related to device therapy in atrial fibrillation, and we will conclude with a brief summary. I took this slide from the ATT-TAC-AF study, which looked at the role of AFib ablation in patients with heart failure. So heart failure is a common clinical problem, and if you start to have heart failure, every year pass, your chance of getting atrial fibrillation is probably 5.4% per year. And that happens by several mechanisms. The heart failure, as you know, is associated with increase in the back pressure in the left atrium, with left atrial hypertrophy, which might lead to left atrial fibrosis and formation of substrate within the left atrial body, which predispose patient to atrial fibrillation. If you start with atrial fibrillation, even in the absence of the heart failure, you are likely to get heart failure. And the chance that you get heart failure is probably 3.5 per year. So any patient with newly diagnosed atrial fibrillation and they don't have any history of heart failure, their chance of getting heart failure after the diagnosis of atrial fibrillation is quite high. In 2 years, probably at least 1/4 of them will get heart failure. So the chance is 3.3 in a different study. In average, it's 3.3 per year. And why does atrial fibrillation lead to deterioration of the LV function, and why atrial fibrillation affect patients with heart failure with further deterioration of their LV function? That happens for 3 reasons. The first one is the loss of atrial contraction or the atrial kick, which is a major contribution to the cardiac output, especially in patients with diastolic heart failure. In addition, the RR interval variability or the irregularity of the heart rate will affect the stroke volume and leads to decreased cardiac output. That will stimulate the hormonal cascade, neurohormonal cascade, and start the heart failure syndrome. In addition, patients who has atrial fibrillation with rapid ventricular rhythm are predisposed to heart failure because of energy depletion, depletion, as well as abnormal calcium handling with the myocytes. So heart failure will cause atrial fibrillation, and atrial fibrillation will cause heart failure. It is a vicious circle. So our approach to patients with atrial fibrillation, we usually start and stress on stroke prevention. Almost everybody with heart failure and atrial fibrillation will require anticoagulation because these patient population are at high risk of stroke, and this is usually achievable by NOAC or warfarin therapy. The second strategy we consider for management of atrial fibrillation is the rate control, and we are limited in patients with heart failure. The best things to use is a beta blocker if you decide in rate control, and in some cases digoxin. In extreme cases, you might also consider amiodarone for rate control. The maintenance of sinus rhythm strategy, we'll talk in detail about this in few minutes. However, we have pharmacological and non-pharmacological ablation strategy to maintain sinus rhythm. When it comes to the pharmacological, also again we are limited with medication. We can't use class 1 and class 1C medication. The only most appropriate medication to be used is only class 3 or amiodarone in this country. So as I said, stroke is a potential and the major problem in patient with atrial fibrillation and heart failure. Almost everybody will require anticoagulation. And when you think about the risk of stroke, think about the other side of the equation, which is the intracranial bleeding. What about the classification of the atrial fibrillation? Paroxysmal atrial fibrillation, persistent atrial fibrillation, long-standing, persistent, permanent. Does it have anything to do with the risk of stroke? The answer is no. Regardless of the type of atrial fibrillation, paroxysmal or persistent or long-standing, persistent or permanent, does not affect the strategy for stroke prevention. However, the only classification which might affect your decision whether this is a valvular or non-valvular atrial fibrillation. And what is the definition of non-valvular atrial fibrillation? It is atrial fibrillation in patient who does not have rheumatic mitral stenosis, who does not have prosthetic valve, and they didn't have any history of mitral repair. Any patient who doesn't have these factors is considered non-valvular atrial fibrillation. In patients with non-valvular atrial fibrillation, we use the SHA-MC score to assess the risk of stroke. And as you know, heart failure is a part of this. So in a patient with heart failure, the SHA-MC score is at least 1. Therefore, almost every patient with heart failure will need anticoagulation. If it's non-valvular, like in our patients, most of the patients, then the choices is between warfarin or the novel oral anticoagulant. If it's valvular, then your only option is warfarin therapy. The other side of the equation is the bleeding, and we have a very elegant clinical tool to look at the risk of bleeding in each individual patient, which is the HAS-BLED score. I'm sure you are all aware about it. And patient who has a SHA-MC score more than 3 qualifies. They are high risk for bleeding, and you should consider an alternative approach of stroke prevention. This is the European guideline regarding stroke prevention. I'm sure all of you are aware of it. Most patients with atrial fibrillation, whether they have heart failure or not, will require anticoagulation. This is a paradigm shift in our thinking. In the past, we used to say, which patient with atrial fibrillation will need anticoagulation? Nowadays, we ask the opposite question. Which patient with atrial fibrillation does not need anticoagulation? As a fact, most patients with atrial fibrillation, whether they have heart failure or not, they will require anticoagulation. And a very few patients who are at very low risk, as defined by the SHA-MC score, they don't need anticoagulation. So if you had a SHA-MC score of 0 or 1, and 1 is because it's female sex, then these are a very low risk patient, and they should not be considered for anticoagulation. Otherwise, everybody else should be anticoagulated. In patients with heart failure, I mentioned, their SHA-MC score is at least 1. Therefore, most of them and almost all of them, they will need anticoagulation. If you have a patient with valvular AF, then the only option is warfarin. Non-valvular, you have 2 options, warfarin or NOAC. What about patients who are at high risk of bleeding and they are at the same time high risk of stroke? What shall we do with them? We have alternative technique to prevent stroke, which is left atrial appendage devices. They should be considered in such patient population. What about the rate or rhythm control? And I think this is the most part of my talk today. Shall we consider rate or rhythm control? As a general rule, what factor favor rhythm control over rate control? The factor which favor rhythm control for rate control in general in any patient with atrial fibrillation is if the patient has paroxysmal atrial fibrillation, if he has newly diagnosed atrial fibrillation, if he is more symptomatic, if he is young, his age less than 65, he has no hypertension, and if the patient has heart failure and we think this heart failure is related to atrial fibrillation, and of course if they are naive to antiarrhythmic medication. This group of patients, and heart failure is one of them, we should always consider rhythm control rather than rate control. If we come to the guideline, there is a special section about patient with heart failure. So patient with heart failure, if you think the heart failure is related to atrial fibrillation, then catheter ablation might be your first option if the patient wish to proceed and accept the risk of the procedure. If the patient does not want atrial fibrillation ablation, then your choice is probably long-term amiodarone therapy. So heart failure actually might push you to consider atrial fibrillation ablation early if you think the heart failure is actually related to the atrial fibrillation. So a case scenario, 44-year-old female with non-ischemic cardiomyopathy for 3 years presented to the ER with palpitation, heart failure symptom for 3 days. She has no chest pain, syncope, or pre-syncope. She is not diabetic, not hypertensive, and she has no history of dyslipidemia, and she has no previous stroke or TIAs. Her medication include ACE inhibitor, beta blocker on target doses, in addition to Lasix 40 milligram daily, Aldactone 25 milligram daily. She has been compliant with her medication and diet, and she has been free of symptoms except for the last 3 days. Physical examination, her GFB is elevated. She has irregular pulse, bilateral crepitation. ECG showed atrial fibrillation with heart rate of 115 beat per minute. Echocardiogram was done and showed ejection fraction of 40%, and LA size is 4.2 centimeter. She had mild mitral regurgitation, upper mild TR. This ejection fraction has not been, did not change over the last few years. Lab test was unremarkable, including thyroid function test. Patient received IV diuretics by the ER physician with some improvement of her symptoms, but she's still shortness of breath. She admitted to the hospital for further management. My question to you, what is the most appropriate next step for stroke prevention in this patient? Choice number 1, aspirin, low dose. Number 2, no therapy. Number 3, aspirin, high dose. Number 4, NOAC. This should be straightforward. Does she need anticoagulation, aspirin, or which one? Who will choose aspirin? So 1 or 2 only choose aspirin. Who will choose NOAC? So the majority choose the right answer. Warfarin is okay, but the only option here is NOAC. This patient is a candidate for stroke prevention because what her CHA-MC score, she's a female and she has heart failure, at least 2. So she is a candidate for anticoagulation, and aspirin has no role in the stroke prevention in patient with atrial fibrillation. The most appropriate initial therapy in this patient, so many choices. Would you give Sutalol 160 milligram twice daily? Would you do jump in her chest and do cardioversion in the ER? Would you give flecainide pill in the pocket approach? Would you consider immediate atrial fibrillation ablation? Would you consider TE-guided cardioversion, digoxin therapy, or AV nodal ablation and biventricular pacing? So many choices, but one right choice. So it's straightforward. This patient is symptomatic. She has rapid atrial fibrillation. It has been for 3 days, so you cannot do cardioversion without TE guidance. So the correct answer is TE-guided cardioversion. Flecainide should not be used in patient with heart failure, and AV nodal ablation is a last resource. It's not in the first presentation. And what about digoxin and verapamil? Rate control is not the best option in this patient. However, even if you consider rate control, you would not give verapamil. So double error in this line. So digoxin could be used, but verapamil not. But rate control is not the best option. Patient had successful TE-guided cardioversion with improvement of her symptom. She was started in amiodarone therapy for maintenance of sinus rhythm, but she stopped amiodarone because of side effect, intolerance, and she had recurrent atrial fibrillation of amiodarone. Patient was taken to the electrophysiology lab, and she had successful ablation of the pulmonary veins, in addition to substrate ablation within the left atrial body and lines. It's important that to say that if in general, in patient with paroxysmal atrial fibrillation, we do only pulmonary vein isolation as the first line. However, in patient with heart failure, it has been shown that if you do only pulmonary vein isolation, the survival free of recurrence is probably 33%. And if you want to achieve good outcome from ablation in patient with heart failure, you should do more than simply pulmonary vein isolation. Patient did very well after ablation. She's off antiarrhythmic therapy and she has been stable. So, as I mentioned earlier, patient with heart failure has significant substrate in the left atrial body. In patient with paroxysmal atrial fibrillation, mostly the triggers comes from the pulmonary veins. We do have also non-pulmonary vein trigger from the CS, the vein of Marshall, or from the right atrium or the SVC. However, in patient with persistent atrial fibrillation and in patient with paroxysmal atrial fibrillation and heart failure, we have a lot of substrate within the left atrial body. Therefore, the ablation should not be limited to pulmonary vein isolation, but also we do ablation in the left atrial body, the posterior wall, and roof line, isthmus line in addition to that. What is the outcome of AFib ablation in patient with heart failure? There is several non-randomized, some of them are non-randomized, most of them are small study over the years since 2004 which looked at that issue. However, these studies are generally small and mostly non-randomized. What did it show, these studies? So the success rate of atrial fibrillation ablation in patients with heart failure range from 50% to 85–90%. So there is a wide variation in the outcome or the success rate with patients with heart failure. And what is the impact of atrial fibrillation on heart failure itself? As you see, most of these studies, except probably this one, when you ablate the atrial fibrillation, their ejection fraction will improve. So the outcome, at least when it comes to the left ventricular ejection fraction after AFib ablation, is good according to this data from small studies. An important study which was published earlier this year, the AA-TAC-AF trial, which was published in March 2015, which randomized patients into atrial fibrillation ablation versus amiodarone therapy. The result from this study showed that patients who were randomized to the AFib ablation arm, their recurrence-free rate is about 70%. So 70% of these patients with a long-term follow-up had no recurrence from atrial fibrillation after ablation procedure. However, patients who were in amiodarone therapy, you know the amiodarone is the most effective antiarrhythmic we could use, and probably is the only drug we could use in AFib in this country. The success rate or the survival free of recurrence at 1 or 2 years is probably less than 35%. So most of the patients who are in antiarrhythmic medication will have atrial fibrillation recurrence. Most of the patients who underwent ablation has no AFib recurrence. What is the impact of the no recurrence in heart failure itself? The left ventricular ejection fraction has significantly improved in the ablation arm as compared to the antiarrhythmic arm. The 6-minute walking distance also has improved, and Minnesota Living with Heart Failure questionnaire had significant improvement in patients who underwent ablation as compared to patient who has been in medical therapy only. So we know now from this study, which is intermediate study, I would not say a large-scale study because the total patients were about 205 patients, and they have 100 in each arm. It showed that the AFib ablation is effective, and it has impact on the left ventricular function and the functional class. To make a final verdict whether we should send everybody to AFib ablation, or we should wait. We will, I think in 2016, we will have the data from two large randomized clinical trials. The first one is the RAFT study, which is a Canadian study in about 8 Canadian centers. The second one is the Castle AF study, which is an international European study, and I think there is more than 20 centers involved in this Castle study. Until we get the result of this study, we cannot make a solid final conclusion, and we don't know yet the impact of atrial fibrillation ablation into the mortality or the hospitalization rate in patients with heart failure. So in summary, AFib is common in heart failure and often disabling arrhythmia. The goal of AF therapy are to prevent thromboembolic events and to improve patient quality of life. Decision to anticoagulate should be based on patient risk factor, and almost all heart failure patients with atrial fibrillation will require anticoagulation. Few drugs are available for rhythm control strategy in patients with heart failure, and they are much less effective. AFib ablation should be considered, especially in patients with heart failure related to atrial fibrillation. Thank you for your time.
Thank you, Yahya. So are you leaving us? You have
Yes.
time? Okay.